Good evening to all the highly respected dignitaries. Happy Doctors' Day. 2 years back, our journey for this academic activity started on Doctors' Day from a small branch of Maharashtra, Raigad IIP. It was a brainchild of then office bearers, Dr. Hemant Gangolia, Dr. Jay Bhandarkar and others, and the Doctors' Day was celebrated with the first episode. We express our gratitude for it, and also we want to thank Maharashtra IIP for continuation of this activity in this year also. Now, may I request one of the young and enthusiastic executive member of Raigad AHA, Dr. Shilpa Nambiar Gandhi, to take over the charge for further proceedings. Dr. Shilpa, please.
Thank you so much, ma'am. Good evening to all the respected seniors, colleagues and friends. Wishing everyone a very happy Doctors' Day. Thank you for joining us on yet another session of Journal Journey. So this is we have completed 1 year already, 2 years already. So it's our privilege to have with us all our esteemed guest of honor, Dr. Satish Devpujari sir, and our two experts for today, IIP President-elect Dr. G.V. Basavaraja sir and Dr. Sara Dhanawade ma'am. Before we start today's session, I'd like to request our Maha-IIP President, Dr. Ramakant Patil sir, to address the session, please.
Thank you, Shilpa. Thank you, Dr. Chitra Kulkarni, Madam, Mohanty sir, for keeping this flame ongoing and with more and more efforts. It is really very heartening and gratifying. And what a golden, good coincidence that we have got 3 stalwarts from intensive care of CIIP. Professor Emeritus Dr. Satish Devpujari sir from IGMC Nagpur, Professor Dr. G.V. Basavaraja sir from Bangalore, and Professor Dr. Sara Dhanawade madam for Bharati Vidyapit. And this without any single gap for last 24 months. This is 25th episode of Journal Journey, and it was a pleasure and honor to continue this activity under Maha-IIP aegis. And I really congratulate the young guns of Maha-IIP, Dr. Tejaswini Deshmukh, who is a neonatologist from Bharati Vidyapit Medical College, Sangli, and Dr. Rohan Bobde, pediatric intensivist, to present their articles. And we have got expert beyond article, which will get some learning and enriching experience. Over to you, Shilpa.
Thank you so much, sir, for your constant support and blessings. I would like to invite our Maha-IIP Secretary, Dr. Amol Pawar, sir, to please introduce our guest of honor, Dr. Satish Devpujari, sir.
Thank you, Shilpa ma'am. First of all, Team Maha-IIP welcomes all the delegates, all the speakers, all the experts from our heart. And today is Doctors' Day, and we are celebrating this by academics. That is Journal Journey, which is a combined effort of Raigad IIP and Maha-IIP. Today we have got a guest of honor. I take this privilege to introduce him. Actually, he doesn't need any.
Slide. Yeah, thank you.
Actually, he doesn't need any introduction. Dr. Satish Devpujari sir is a director at Shri Child Clinic, Dhantoli, Nagpur. He is Professor Emeritus at IGMC Medical College, Nagpur. He is also the extra degree he is having, that is, he is adjunct professor.
Amol sir, you are mute. Amol sir, please unmute.
Sorry.
Yeah.
He is an adjunct professor of practice in mechanical engineering in VNIT College, Nagpur. So I think there will be only few of us, few of the doctors who are also in the field of engineering, and he is one of them. He has done MBBS from Nagpur University. Then he has done MD from again Nagpur University. He has done DCH from Nagpur University again, and he was university topper. and he has also done MNMS from this National Academy of Medical Sciences, New Delhi. His current portfolios are: he's honorary director at Center of Excellence and member board of management DMI MS Nagpur. He's founder chairman of National Pediatric Intensive Chapter from 1998 to 2000. Then he was president of Society of Pediatric Cardiac Critical Care. Then he is director of academics at Nelson Mother and Child Care, Nagpur, one of the very finest hospital for mother and child care. Then he is a member of planning and monitoring board of DY Patil Education Society. Then he is chairman academics at Nelson Hospital again. He is on editorial board of Journal of PICC India. He is director of Center of Excellence in Medicine and Applied Computing at DMI MS Nagpur. Then he has various past portfolios, and because of short of time, I won't be able to read all these things. So I welcome Dr. Satish Devpujari sir for this special episode of Journal Journey. Thank you. Thank you.
Most important introduction of Devpujari sir is one of the pioneer of pediatric intensive care in India.
Thank you. Over to you, Shilpa ma'am.
Thank you so much, sir. And thank you and welcome, Dr. Satish Devpujari, sir. Now I request our Raigad IIP President, Dr. Vikas More, sir, to welcome our dignitaries.
Thank you so much, Dr. Shilpa, for giving me this opportunity. I am Dr. Vikas More. On the behalf of IIT Raigad, I wish you happy Doctor's Day. I feel so proud that a small journey started from such a small branch, now going to such a proportion. It is just due to the perseverance of our respected Dr. Niman Monty sir, Dr. Hemant Ganguly sir, Dr. Chitra Kulkarni madam, Dr. Jayant Bhatta sir, and they are really working hard to keep this flame alive, and it is really blessed by the respected Ramakant Padi sir at Maha IIT level. That's how we are able to cater this service to the state level. And one more thing is that we are so blessed to have Dr. Satish Devpujari sir today, Dr. Basraj sir, Dr. Dhanodi madam, Dr. Moite sir. I have spent 3 years of my life in Vidarbha, so I know the stature of Devpujari sir is just like a god. He's like a god of pediatrics in Vidarbha region. So everybody turns to Devpujari sir for any difficulty in Vidarbha region. I know, I have witnessed that, and sharing a screen with him is just like a dream come true. Similarly, like Dr. Basraj sir, it is again a dream come true to the president-elect is now joining a team online with us. It is again a privilege for us. Thank you so much, sir, for accepting our invitation. And I'm so, I really feel proud that this reading habit, reading the article from the journal is percolating into the deeper and deeper section in the interior parts of Maharashtra. Our team is encouraging the MAHAIP team is encouraging the pediatricians from small towns to come ahead and read the articles and discuss under the guidance of experts. So it is a very welcome initiative. I congratulate the team for this unique initiative. Over to you, Dr. Shilpa Nandia.
Thank you so much, sir. May I request our guest of honor, Dr. Devpujari, sir, to give his blessings, please.
I'm thankful to all of you for inviting me here, and it's a wonderful platform. Amazing. I've been following this over a period of time, and why I said right at the beginning that I want to be a silent observer, because I know there's so much to see and learn from all of you, and I mean it. I'm not just saying, because you all are the pillars of how things are going to change in our country, and I think with those few words, I really appreciate you inviting me here. Thank you.
Thank you so much for your kind words, sir. request our President-elect Dr. Basalraj sir to share your messages.
Thank you, Dr. Shilpa. Respected our President of MAHA-AP, Dr. Ramakant Patil, Secretary Dr. Amol Pawar, our Dean in the Pediatric Critical Care, none other than Satish Dev Pujari, Sara Dhanwade Madam, and IAP Raigad branch members Chitra Madam, Shilpa, Neha, Mahesh Moite, one of the most respected our pediatric intensivist and my close friend, and all other dignitaries. So really, I am very thankful to the IAP Raigad branch and MAHA-AP for starting in a journey in the way back 2 years back on the Doctor's Day. Once again, I take this opportunity to wish you happy Doctor's Day, and also the academics which has been taken to the greater heights by MAHA-AP and Raigad across India, where MAHA-AP, which is been recognized for doing a great academic work. With these few words, wish you all the best for this program. I don't want to take much time in between. I'll be in between. Thank you.
Thank you so much, sir. So let's start our session. For that, I invite our Raigad IAP Secretary, Dr. Ajay Kohli, sir, to please introduce our first expert and the speaker.
Dr. Neha. Yeah.
Dr. Ajay Kohli, sir.
If Dr. Vikas is present, he will introduce.
Vikas,
Yeah,
Mure, sir,
yeah.
you can.
Yeah. Yeah. So I'm so happy to introduce
I think there is some connectivity issue. Sir, you are not audible.
who is the Dean of Bharati Vidyapeeth, Medical
Sir, your
College,
connection.
Sangli, and she has a vast teaching experience. Texts like Past Technique of Pediatrics, second edition. Hello, hello. Am I audible?
Hello.
Yes,
Audible?
sir.
Am I audible?
Your voice is breaking, sir.
Okay.
Now you are audible. Yeah.
Yes.
Yeah. Yeah, I'm so happy to introduce Dr. Sara Dhanwade Madam, who is a Dean of Bharati Vidyapeeth Medical College, Sangli. She is a working as a professor, Dean and Professor of Pediatrics. She has a vast teaching experience of more than 35 years, and also as a PG teaching from last 23 years. She has almost 25 publications to her credit and contributed to various textbooks. And she has received various awards, like some to mention, like Asia GCC Women Health Leader Award, Pediatrics 2022. So there are so many achievements, but short of time, I'm just, I can't read them, all of them, but we are really thankful, madam, for gracing this stream. Over to you, Dr. Shilpa.
So can you also introduce our speaker for tonight?
Yeah, we are having a young dynamic presenter, Dr. Tejaswini Deshmukh, done her MBBS from Vasundhara Power Medical College, Nasik, and MD Pediatrics from Datta Medical College, Wardha. Right now working as a senior resident at Bharati Medical College, Sangli. She has done a fellowship in neonatal intensive care at
Sir is not audible. Yeah. Over to Dr. Tejaswini. Please start your presentation. It's okay, doctor.
Tejaswini, please unmute yourself.
Have some publications in a
Dr. Tejaswini is requested to start her presentation.
Good evening, everyone. Good evening to one and all present here. Myself, Dr. Tejaswini. And today I'm going to start the journal journey session with this paper, A Bedside Equation to Estimate Endotracheal Tube Length for Infants, published in the Journal of Pediatrics. The study was carried out at the Evelina London Children's Hospital, UK by Burnhill et al., published in the volume 2016, May 2023.
Doctor, your slides
Hello?
are not moving.
Yeah, ma'am, there's
Tejaswini?
some error.
Yeah. Okay.
Click on the slide now.
Look, she had done.
Go to second slide.
So intubation in infants warrant quick and accurate ET tube insertion and embodies timely ascertainment of its position. Although various methods
Screen
like
is not visible. Your screen is not visible.
is it visible now?
Yeah, it is visible.
Yes. Although various methods like chest X-rays, capnography, ultrasounds, external digital tracheal palpations, video laryngoscopes, etc., can be used to determine accurate placements of ET tubes, but bedside estimation of ET tube length remains the most simple but efficient modality with a low margin for error in predicting accurate placement of the ET tubes. Selection, insertion of appropriate size and length of the ET tube is of critical importance, as we know. Correct positioning of these tubes within the trachea is essential, and malposition is associated with increased morbidity and complications, particularly when the tube is placed low. Deep placements of the tip can irritate carina, causing sympathetic stimulation, also leading to endobronchial intubations, which ultimately lead to air leak syndromes like pneumothorax. But on the contrary, shallow placements of ET tip increases the risk of accidental extubation. So why was the need for the study? All the formulas to estimate the correct length of ET tubes based on age are internationally recognized for children more than 1 year of age. No such universally accepted formulae in infants were previously assessed. The aim and objective of the study were to describe a large cohort of intubated children less than 1 year of age and to establish a bedside formulae for estimation of the ideal ET tube length using comparison of known fixation length compared with the tip position on the radiographs. The study design being retrospective cohort study, inclusion criteria of children less than 1 year on invasive ventilation, whereas exclusion criteria was when the position of the ET tube were not confirmed on chest radiographs and the length of fixation were not recorded. So before going forward, I will just brush up with some terminologies related to cohort studies. So what is cohort? We all know cohort is a group of people who share common characteristics or experiences. The commonest type being prospective, retrospective cohorts. Prospective study are the group of cohort where certain time, which is carried out over a certain period of time, when none of the participants in the study, they have the condition of interest at the beginning of the study, but some are expected to develop disease in the future. Whereas the retrospective study is when the participants already have a known disease or the outcome. But we will look backward in the past to try and determine why participants have been exposed. Though retrospective study is cost effective and it takes lesser time, prospective study has a good strength, also has fewer potential sources of bias and confounding than the retrospective studies. So here in these studies, the retrospective database analysis of around 735 children less than 1 year of age admitted in PICU was done. Chest x-rays were taken both on admission and post-intubation. The ET tube's position was determined by tube-tip superimposition over vertebral body on post-intubation x-rays and recorded by 3 trained medical students. Students were trained by PICU consultant with more than 10 years of experience. And in an event of confusion, when the ET tube position were confirmed by the consultant themselves. Every radiograph was independently reported by pediatric radiologist. And then this data was used to assess for concordance with the medical student assessment using Cohen's kappa coefficient. So this kappa coefficient, Cohen's kappa coefficient is used to test the inter-rater reliability, or if we simply put forward, it is a measurement of the extent to which the data collectors assign same score to same variable. In case of ET tube displacements, comment made by the radiologist consultant were also recorded. And then bedside assessment of ET tube length at nostrils or lip were recorded electronically by the intubating doctors or the nursing staff. Data was analyzed using software package R when multiple intubations by the same route were anticipated. Position and length were averaged to decrease overweighing of the multiple episode or overweighing in the data. Demographics were compared using the Krustal-Wallis and Pearson chi-square test. The linear regression analysis was carried out to identify the line of best fit for ET tubes placed at the second thoracic vertebrae, both for oral as well as the nasal intubations, using weight and age adjusted for gestation. 80% samples of both the groups were used to build the regression model, with the remaining 20% used to test the predictive accuracy using the mean absolute predictive error, that is MAPE, and mean max accuracy. So the MAPE basically is the average magnitude of the error which is produced by a model. So say for example, if the MAPE is 20%, that tells us that the average absolute percent difference between the predictions and the actual values is 20%. Whereas this mean max accuracy, it gives the accuracy rate of the model in percentage. So how close are the actual and predicted values? Similar process was repeated to evaluate if the thoracic vertebrae give the alternative results. Multiple regression analysis was thereafter used to determine the effect, if any, of comorbidities on these data. And then comparison of the accuracy of the generated formulae against the previously published formulae was performed by computing the predicted tube lengths given by these formulae for each record in the data set, and then calculating accuracy matrix, that is mean max accuracy and MAPE. In the results, in total 735 patients in this study underwent mechanical ventilation, with around 1250 distinct ET tube episodes. Of these, in total 65 were excluded due to unavailability of x-rays and 9 were excluded due to unavailability of bedside length measurements. So in total, at the end, they had 1,176 left for analysis, of which 786 were nasally placed and 392 were orally placed. So majority of these patients underwent only one intubation episode, majority, but only 7% had 2 or more than 2 intubation episodes. So as we can appreciate from this table, the demographics for patient by the intubation side. In the left side column, we have this clinical characteristic, that is corrected gestational age in month, weight, the female sex, and the recorded comorbidities. In total of 735 patients were included in the study, of which 390 were nasally placed, who had nasally placed ET tubes, 120 had orally placed, whereas 225 in total had orally as well as nasally consecutively placed. So amongst the clinical characteristic, the gestational age in month was seen to have statistically high significance with the intubation site with a p-value of less than 0.01, whereas weight and female sex did not show any concordance. Recorded comorbidity amongst the whole 735 of the sample size were as large as 63%, that is 467 patients were documented to have recorded comorbidities like the cardiac defect, extreme prematurity, and trisomy 21. So of these comorbidities recorded, they were also seen to have a significant association with the tube intubation site. As we can appreciate here, these are the number of ET tubes at each position divided by the route and then per intubation episode. I would just like to zoom in. Here on the x-axis, we have the ET tube position, whereas on the y-axis, we have the number of tube placements. So on the left upper side, this are the nasally placed, these, and these are the orally placed ones. This is a documented first episode of intubation, nasally and orally, whereas this one below is the second episode of nasally and whereas orally placed. So the conclusion from this diagram we can put forward is majority of ET tubes during their first episode of intubation, both nasally as well as orally, were put at the acceptable position, that is thoracic first to thoracic third vertebrae, or precisely at T2 during the first intubation episode. Whereas in the consecutive episode, a deeper placement of the tubes were appreciated, as we can see. So actually multiple episodes of intubation were analyzed, but due to very minimal data, the pictorial demonstration for the third and fourth and the consecutive episodes was not done. Further, as postulated by the authors, they further compared the model accuracy over these variables, as well as with the previously published model. So both for nasally and orally placed tubes, the variables which were assessed were the age in months, corrected gestational age, weight, the simplified weight, and the previous model which was published by Law et al., the weight included in that very study. So what conclusion they have come up with is the weight both for nasal and orally placed ET tubes was found to be, the mean max accuracy was shown to be as high as 96%, as we can appreciate in the mean max accuracy column for weight, both nasal and oral, was seen to be 0.96 and 0.95, that is 96% and 95%, making it highly accurate model. Whereas the mean absolute predictive error, that is the average magnitude of error produced by the model, was as low as 0.0039 and 0.052. That is lesser the error, more is the accuracy, is what we can say. So how determination of the predictive equation was done? So after averaging the multiple episodes of ET tube insertions per patient, grossly, a total of 281 nasal tubes and 105 oral tubes were found to be positioned at the optimal position, weight, chronological age, and gestational age were found to correlate to the ET tube length with high probability. Later, these were used as input variables to approximate the ET tube length for optimally positioned tubes, and weight was found to be most accurate in exploratory analysis. The simplified version of the regression formulae, so the formulae which was put forward by them was weight by 2 plus 8 for oral placements and weight by 2 plus 9.5 for nasal placements. So simplified version, that is weight by 2, equivalent to 0.5 into weight plus 8 and 0.5 into weight plus 9.5 for nasal placements, were tested for both ET tube subset and found to have a similar accuracy. What were the interaction of the comorbidities? So further analysis was undertaken to elicit whether the high prevalence of recorded comorbidities in the group had an effect on the relationship between weight and the tube length at T2 in the cohort. Multivariable regression showed no statistical relationship between weight or tube length and aggregate comorbidities. Individual comorbidities was also not statistically associated with tube position. A detailed investigation of prematurity also revealed premature children, babies also revealed no increased accuracy in goodness of fit if babies born premature were removed from the data set when performing this regression analysis. So after recording ET tube positions in a large cohort of children less than 1 year of age and studying their association to body weight and age, the authors have formulated two equations to estimate the ET tube length bedside and to validate these against their data. Presence of common comorbidities within PICU, that is prematurity, cardiac disease, trisomy 21, did not affect the estimated ET tube lengths when weight was used, was proposed by the authors. The differences in the demographic distribution of the children undergoing nasal versus oral intubations were present. So as proposed by the authors, the formula, that is weight by 2 plus 8 centimeters for oral ET tubes and weight by 2 plus 9.5 centimeters for nasally placed ET tubes, are convenient for use in emergency situations in which simple calculation using single easily obtained measurement is most desirable. As previously studied by Low et al., this paper, wherein a new formula for predicting tracheal tube length, published in 2006, by using the linear regression analysis, they have formulated 4 formulas, 2 for age group more than 1 year and 2 for those less than 1 year. But the results found showed no clear-cut definition for optimal ET tube position. And also the major drawback of this study was the smaller population of the patients with nasally put ET tubes. The commonly used formula of 3 by ET tube diameter in millimeters, as we routinely use, was also shown to have a very lower predictive accuracy when computed against this cohort, supporting previous data that use of this formula can lead to a high rate of endobronchial intubation. The choice of a single vertebral landmark at T2 aided the development of model with accuracy and prevented the ET tube placements at T4, which are frequent sites for intrabronchial or carinal placements. The average thoracic vertebrae distance in this age group, that is less than 1 year of age, was seen to be 1 centimeter, but the maximum mean error in this study was found to be 0.67 centimeters. Thus, this is to reassure us that ET tubes inserted to a length estimated by this formula will remain within T1 to T3, which is the acceptable position. These are easily remembered formulas and can provide a significant advantage over the reference tables, which may not be handy in emergency situations. So the limitation of the studies were majority of these patients admitted were below 12 kg. So application of this formula above this weight range could not be predicted. The estimations of ET tube length could have been improved by using patient's length. More precisely in elective intubation, because in emergency intubations, neither there is time for length measurement, nor the parents remember the length of the children. Application of this formula in Asian ethnicity needs further validation. X-rays are usually prone to tilting, leads to distorted image if chin position not neutralized. Effects of other syndrome like the Perry-Robinson syndrome were not taken into consideration. And also the gender variability has not been studied in this study. So as we all know that there is a huge dilemma and lot of fear associated with intubation, especially between the postgraduates during the initial years of residency. So a simple bedside formula as this could be very much beneficial while managing patients both in ICUs and casualties. Also in resource limited settings like in SDH or in PHCs where there is a need for resuscitation. Ease of applicability of these formula and securing ET tubes without need for any pediatric or neonatal intensivist. And also with no any ultrasound machine for confirmation can prevent mortality and further complication associated with ventilation. So I would like to conclude saying that the endotracheal intubation, as we all know, is a potentially life-saving measure in infants with hypoxia, cardiopulmonary arrest, and extremely premature lung. So these simplified formulas for bedside assessment for ET tube lengths required for optimal placement of the ET tube tip and are also needed for balanced ventilation. Although ET tube is the most reliable way of providing positive pressure breath, the critical factor determining the maximal efficacy of a positive pressure ventilation is the optimal placement of these tips. Thank you.
Thank you so much, Dr. Tejaswini, for an excellent presentation.
Yeah, please stop share.
Yes, ma'am.
Yes.
I request Dr. Sara, ma'am, to please give your.
Thank you. First of all, I would like to, am I audible?
Yes, ma'am.
Yeah. First of all, I want to thank Maha IAP and IAP Raigad for this wonderful program of journal journey, which is because journal reading is generally considered as an activity only in teaching institutes. So I am extremely happy that the peripheral IAP branches have taken this. So just to kick the ball rolling, we all know that the correct positioning of endotracheal tube is very important. So we either go by the NRP standards guidelines or the PALS guidelines. So earlier we used to use the NRP 6th guideline, which used to use the Tochen's formula, that is weight plus 6 centimeters. Then by 2017, we moved on the NRP 7th edition, the Kempley's formula came, which was based on gestational age and birth weight. You need to look at both the gestational age and the birth weight. Then there is a third one where most of us do it, that is the rough calculation, where you multiply the internal diameter of the ET tube by 3. Then for the PALS formula for children over 1 year, it's age upon 2 plus 12. But none of these formulas, many studies have been done, all these formulas have been found to be not accurately predicting the correct length of the ET tube. So what is the correct length? The recommended position is T2 level, vertebral level, and the acceptable level can be T1 to T3. Okay, now, and chest X-ray is the gold standard. Auscultation, we many times after intubating, we immediately auscultate. It can be taken as a sign, but always we must get a confirmatory chest X-ray. We have now other methods like bedside ultrasonography, etc., but that may not be available for many. Now coming to this particular study, the strength of this study, I would say, is the large cohort of patients which they have intubated patients. It is 1,176 intubations they have looked at. Not many studies have this number. And on top of it, they have both nasotracheal as well as oral intubations. They have a 66% nasotracheal intubation, which is difficult. We hardly do nasotracheal. Their study was done in a particular ICU where a lot of cardiac surgeries and prolonged ventilations were there. Otherwise, you will not get this number of nasotracheal intubations. Even all the other studies do not have this kind of a number. Here, almost nearly more than 60% of their patients had nasotracheal intubations. Secondly, they also had very optimal position of the endotracheal depth was clearly defined. They had taken clearly T2. There was nothing like T1 to T3. It was clearly defined as T3. And they have tried to match the reporting. That was something interesting. The medical students reporting with the radiologist, and they found a kappa value of 0.8, suggesting very good correlation with the medical students who were trained to look at the X-ray and predict the endotracheal tube length. Having said this, in many settings, in my opinion, chest X-ray, there can be a problem with chest X-ray unless we are able to get very good chest X-ray in a sedated and properly sedated child. Because position of the chin, flexion of the neck, then tilting of the X-ray or exposure of the X-ray, if it is not good, we may not be able to exactly, precisely delineate the depth of the tube as to T2. So I suppose this being a retrospective study, they have claimed that the X-rays were done when the child was in sedated position and retrospectively. So this can be a practical problem in, at least in Indian setups. Many times we don't get absolutely good X-rays and we can have problem getting it. But having said that, that is the most important thing. Secondly, they have also given a predictive accuracy. That is very good. The predictive error, according to them, from this is only 5% error. So these are the good things about these studies, which I have mentioned. And they have studied the corrected age, chronological age, weight, and they have also looked at the gender. Now coming to some of the other limitations which we just pointed out. I was just looking at it. If you see the age limit of the children, the median and IQR, it is ranging between 3 to 6 kilos, 3 kg to 6 kilo. That is the median and the 2 quartiles. The first and that means the 50th centile and the 25th to 75th. So most of the children are falling in that range. So I am not too sure whether this formula will be really valid up to what age. Although the authors claim that this can be used up to the age of 12 or even maximum up to 13 kg they claim, because that happens to be the 99th centile for 1 year child. But they had in their study just one child of 12 kg. So this is something we need to take it with some caution. Is this formula, the formula will be this accurate in children who are above 6, 7, 8 or higher weight range? Although it is claimed that it is up to this thing. That is point number 1. Secondly, length has not been considered. It is the authors have mentioned. But as you know, the length of trachea increases with height. So length has not been considered in this. And whether considering length would have made any difference, that is another point to be considered. And of course, the other limitation is being a retrospective study. It is prone for biases. And having said all this, again, this is done in UK children. And I feel that this formula should be not retrospectively, prospectively evaluated in Indian infants. There are very few studies on infants alone. Most of the studies I was going through was either in neonates or in older children. This is exclusively done in infants. So if before we really rely 100% on this study, I feel that good prospective studies should be done in India to evaluate this. This is something I wanted to share with you all. I would like maybe Dr. Dev Puchari sir and Mahesh Moite sir, any comments on the things?
So, in fact, I agree with Dr. Sarah for the detailed analysis. And data is skewed because whether it can be applied to age right up to 12 years of age is a big question. And if you look at the number of subjects involved, there's a possibility at an increasing age. So it's not uniformly distributed, and this may not be very correctively done on the analysis that they have pursued in this study. And I entirely agree that we need to look at the ethical, the ethnic considerations. So we may not apply this entirely to the Indian population. And definitely a study will have to be done as related to our population. So, but of course, the study is very good. The common formula we would use was age divided by 2 plus 12.
Plus 12.
Yeah, we understand the limitations of this. And a lot more studies will have to be done for the length of ET tube. Surely. And I mean, this cannot be really universally applicable. And there are a lot of ethnic differences in the endotracheal tube, in the trachea and the mid-tracheal length. So I think we need to consider that point. But I agree, you've done a perfect analysis, Dr. Sarah, and I entirely agree with what you've said.
Just
Even
I want to
though
ask.
Mohite sir, yes.
Yeah, Dr. Tejaswini, I wanted to know whether this is a single center or multi-centric study.
Single center.
No, so this is a single sector study.
So that also becomes a limitation of the study.
Yes,
Because you have a defined population, a defined cohort, which this cannot be extrapolated to across the boundaries. You know, the Scandinavian children are the largest one, and Indians are at the other end of it, especially the babies. The average birth weight is 2.7, Scandinavian average birth weight is 4.5. So obviously the length also accordingly changes, and obviously if I was just calculating, say about 10 kg child coming to me, how much I put the tube inside, maybe around 12 or 13 number. And if you put that formula into this will come to around 13. Looks reasonably accurate. By I was just calculating in my own mind how the things will work. So putting the same number for a 2 kg child, I'll be putting by this formula 9 number, which most of the times I have to pull out the tube outside, because my tube is at around 8 number at that time. Otherwise I'll be intubating. So perhaps this has to be studied more in the Indian population. Second is, I think you have defined the qualification of the trainer, that is 10 years experience of the teacher. They haven't defined how the intubator was trained. You just said that these were trained by the trainers, but we don't know the accuracy and kind of a qualification of the intubator. That also makes a huge difference. If you recall the pulse guideline, the best person in the scenario should intubate. And in fact, the whole ETCO2 monitoring in the Europe has come because of the poor training of the intubator on the site or even an ICU. So it's mandatory in them to confirm the tube by ETCO2. Where in the Indian population, ISO was our intubators are far more expertise. We hardly feel that problem. Whether that is also going to contribute in the whole study outcome. I think rest of the parts are very well said by Dr. Sarah Madam and Dr. Dev Pujari sir. So maybe a multi-centric will be a more desirable in this rather than just one single center with some better protocols.
Thank you so much, Dr. Sarah ma'am, Dr. Sritish Dev Pujari sir, and Dr. Mohite sir for your comments. So let's go to the second article. To introduce our next expert, I request Dr. Mahesh Mohite sir to please introduce Dr. G.V. Basalvaraja sir.
He requires introduction. Actually, I don't have his CV in hand, but I can talk for hours about Basavaraj.
We'll be sharing on the screen.
We are sharing the CV, sir.
Don't share. That will be insulting to Basavaraj if he requires the sharing in my hand, because I know him for almost more than 15 years as my colleague in PIC chapter. He was the ex-president of Pediatric Critical Care chapter. Then he was a secretary for 2 years in the worst period, probably most challenging period of IIP, that's in COVID period. And you can see the way he has worked in that period. He is absolutely workaholic person. He has the best possible memory that I know of in the IIP circuit today. He remembers everybody's name like just out of word. I heard Mr. Sharad Pawar has that kind of a memory of knowing everybody by name. So Basavaraj is, you may, okay, in a good sense, you can say Sharad Pawar of IIP. And amazing memory. I always admire his memory. As far as his academic achievements, he is a professor of pediatrics in Indira Gandhi Children's Hospital. He is the head of the unit of PICU. He's one of those rare kind of IIP presidents who will be academically so highly talented and well versed with most of the specialties in this. I'm sure we are going to have a wonderful year ahead. I will not be reading his CV because I personally know him for last 20 years, and he's one of the most admired person in the circuit, well deserving to be a secretary as well as president of IIP, incoming IIP. And I'm really excited to wait for his tenure in the IIP. I'm sure he's going to take IIP to great heights in his tenure. It's over to Basavaraj.
Thank you so much, Dr. Mahesh, for such a highly words, which is really because of the way we all worked for more than 15 years along with our pioneer in the pediatric intensive care, Dr. Satish Dev Pujari sir. So we eagerly looking forward to this journal presentation. After that, we'll come back.
Yeah. Now the second presenter, please share the slide, Dr. Neha.
Uh,
Dr. Ajay Kori, our Secretary of Raigad IIP, is requested to introduce Dr. Rohan Bobde.
Hello. Good evening, all. Thank you, Dr. Chitra ma'am and Dr. Shilpa ma'am. With great pleasure, I introduce our next young and dynamic speaker for the second session of today, Dr. Rohan Bobade. Sir is a pediatric intensivist presently attached to Parijat Hospital, Amravati. Sir has done his undergraduation from SRTR GMC Ambizogai and his post-graduation from Baroda Medical College, Vadodara. He has completed fellowship in pediatric intensive care at BJ Wadia Hospital for Women and Children, Mumbai. Sir was also in the past as a consultant pediatric intensivist in Ravi Children Hospital, Mahbub Nagar. Over to you, sir. Please start the presentation.
Thank you, sir. Maharashtra, the second most populous state of India, has a rural population of around 54%, which consists of ghats, plateaus, and a coastline. Catering to such a population with only intensive care provided in urban sectors is very difficult. So, to put more light on the present situation, we have our next topic. So, Dr. Rohan Bobade, sir, please start your presentation.
Oh no.
Can you all hear me?
Yes,
all
sir.
good.
Yes, sir.
Yes. Thank you very much, ma'am. Good evening to everyone and happy Doctor's Day. I'll be reviewing the article of setting up a PSU in community and rural setting. This article was written by Marvin B. Mata, Alexander Santos, Judith Ugale Wilson, and this article was published in Pediatric Clinics of North America in 2022 with impact factor of 3.58. There are PSUs can play a crucial role in bridging health inequalities in providing high quality care in rural setting. It requires multi-stakeholder collaboration to meet community needs and allocates resources to meet standard of care. Training of dedicated and skilled multidisciplinary team is the most critical investment that you require in a setting of PSU. There are multiple challenges we face while setting up PSU in community. It has limited resources. It has lack of pediatric subspecialties, lack of equipments, technology, and financial capacity. Formation of dedicated, skilled, and resilient team is the biggest challenge we face. We can find parallel to these, though this paper was published in US. The same situation we can find in our smaller cities, and that's why we are going to go through this article. There are a few definitions given in this article. A community-based PSU, it was previously labeled as level 2 PSU, and it is something that is not located in a metropolitan area. It is situated in general hospital, rural and suburban area. A tertiary PSU is something that was previously labeled as a level 1 PSU. It deals with advanced critical care like ventilation, dialysis, etc. A quaternary PSU is a specialized unit for something like cardiovascular surgeries, transplants, trauma, and cancer. So in India also, we have a few quaternary PSUs and a few more are coming up. And there are many tertiary PSUs in bigger cities, but the issue is with the smaller cities where there is lack of critical care for children. So that's where community-based PSU comes into the picture. So why do we need this community PSU? There is even in US in last few years there were though the number of PICU beds were increasing, it was mostly increasing in the bigger cities. The community PICU beds were significantly decreasing since last 4 to 5 years. This variable spread of resources widens the gap in access. The PICU influences capability to handle emergencies such as surges from disasters, mass trauma, and pandemics or epidemics. It also bridges the gap by bringing pediatric critical care closer to home. You don't want a critical care patient to go miles and miles away for in his serious condition. So how to set up a PICU? We need a focused mission to help improve the children's health and quality of life by bridging the gaps of care. There has to be a vision of delivering an integrated health delivery system and maintaining sustainability. High quality care need not be expensive. You can use affordable alternatives also to provide a quality care. And smaller setups can give better ratios of physicians and nurses per bed. There is evolving expectation in community about minimal standard of care. Limited resources make it difficult to allocate these services. It is difficult to find trained staff in rural setups, and retaining them is even more difficult. And more than compensation, when the rural physician, when surveyed, preferred connection, comfort, and confidence. So planning and designing of a PICU should be according to community needs and availability of resources. There should be proper planning, allocation of resources, and investment in education and training of healthcare providers. And a proper teams has to be formed. The team of administration that deals with capital planning and budgeting, design team that consists of clinical and non-clinical staff that deals with the functioning of a unit, and construction team that comprises of engineers and architects. So while designing a PICU, 6 domain set by Institute of Medicine must be met. That it should be safe, effective, patient-centered, should provide timely services, efficient, it should be efficient and equitable. Short and long-term goals need to be prioritized, and objective can be formulated to specify the steps to achieve these goals. Any PICU requires these 4 S's as fundamental building blocks. First one is staff. We need a dedicated and trained staff to run a PICU. Staff consists of equipments and machinery. We require a safe and dedicated space for our unit, and a system. Apart from doctors and paramedical staff, we need a non-practicing people who runs the system and looks after logistics. Geographical location generally impact these 4 S's. We have to look after population we are serving, prevalent diseases in that population and geographical area, availability of medical providers, capacity of for infrastructure and support services available. And keeping the unit operational requires careful control of fixed and variable costs. There is running cost of for a PICU, and cost per patient will be more in lower volume facilities. Networking with the tertiary and quaternary facilities can fill the gaps. Those are not locally available. Thompson and colleagues have given a few guidelines, performance guidelines and prescriptive guidelines. Performance guidelines deals with functions that needs to be accommodated, and prescriptive guidelines tells us about the physical design of the space. Optimizing both these creates efficiency in daily workflow process, promotes safety, and improves staff and patients' satisfaction by providing safe and healing environment. We must always follow local and federal policies and regulatory standards. A PICU should always be a separate and distinct unit in a hospital. It should promote physiologic, physical, and emotional healing. And engineering should improve staff performance, enhance patients and patient safety, and improve patient comfort. By determining how much beds a PICU should have, it depends on 3 things. That's accessibility, safety, and efficiency. Accessibility can be seen by number of days per month with at least 1 empty bed. Number of patients transferred per month due to full unit gives idea about safety, and number of beds per month with beds underutilization gives idea about efficiency. So roughly 5% of hospital beds can be dedicated to PICU, 6 to 8 for less than 100 beds and 8 to 12 for 100 to 150 beds. Single beds room should be preferable to multi-bed bedrooms. A space of at least 250 square feet for each patient is required, as a critical child will require space for machinery and equipments and healthcare staff working around that patient. Leveraging advances in technology like computerized order entry, clinical decision support tools, barcoded medication administration, smart IV infusion pumps, electronic prescriptor, and automated drug dispensing system can help reduce error and improve outcomes in these setups. There has to be a clearly defined leadership and chain of command and responsibility for better communication, decision making, and accountability. A PSU has to have a board certified pediatric intensivist who have completed fellowship training, serves as medical director and leader of the team. He looks after clinical and administrative duties like developing policies, training of staff, planning and budgeting, quality and safety improvements. We also need a dedicated and skilled multidisciplinary team with knowledge, training, and skills with defined duties and responsibilities. Nurse to patient ratio should ideally be 1:1 in critically ill patient, or otherwise 1:2 for one patient should suffice. There are something called advanced practice providers in US that works as assistant physicians and take decisions in PSU, and they have found that these are they have given better results instead of traditional nurses. Support staff should consist of, say, respiratory therapist, pharmacist, dietitian, social worker, speech language pathologist, physical and occupational therapist. While transporting a child from a community PSU to a higher center, you need a physician, nurse, respiratory therapist, and paramedics. Number of personnel will depend on condition of the patient. And as the number increases and the equipments will increase, the expense will be a crucial factor. For our nursing staff, we need continuing education and training. Updates on new knowledge and solidifying existing skill has to be looked at. And employee and patient feedback and performance review should be done periodically. There should be a process while recruiting the healthcare professionals. The first one is credentialing. Obtaining and verifying qualifications of healthcare providers should be done. In US, there is a Council for Affordable and Quality Healthcare. It is a non-profit organization, and that maintains a database for and here you can verify the credentials. Based on credentials and performance, the scope of services can be granted to an individual, and staff privileges should be periodically reviewed. Clinical decision support systems and clinical pathways are interventions that enhances decision-making in healthcare providers and improves patient safety by incorporating evidence-based guidelines. There is something called care coordinators working in the hospitals who looks after patient care activities and shares information among all the participants. They help patient to successfully meet their management goals. As you can see in the diagram, it's an ongoing process of assessment, goal setting, care planning, and continuous monitoring. Care coordination, characteristics of care coordinations are patient and family centered, proactive, planned, and comprehensive. It promotes self-care skills and independence and emphasizes cross-organizational relationships. There are barriers to care coordination. The primary care system is already overstressed, and adding more responsibility is can be more cumbersome. There is low computerized records, dysfunctional payment system, and lack of integrated system for care. When a child is technology dependent in a sophisticated unit, and we want to shift that child or make a transition, there is need of an intermediate care unit, like a step down unit. In that unit, a structured educational program to the caregivers can be taken, and 24 hours room in with caregivers can be done, where the caregivers are told how to take care of that child and how and what to expect in future. There is definite role of telemedicine. Real-time audio-video communication between clinicians and care coordinators and patients can be done, which eases the follow-ups also. To summarize, the bigger cities in India have high level of PSU setups, but the issue starts with when we go to level 2, tier 2 and tier 3 cities. In these cities, we don't find a proper level 3 PSU or even a level 2 PSU, and these gaps causes more and more mortality in these areas. So networking with higher centers can help our setups as well. And we should start investment in education and training of staff and healthcare providers. There should be programs where nurses can be taught to take decisions in critical care setup. And leveraging technology will facilitate networking and will help create sustainability. Thank you.
Thank you, Dr. Rohan, for presenting this huge topic in less than 20 minutes, I can say. So I request Dr. Basal Raja sir to please share your expertise and comments on this article.
First of all, let me congratulate Dr. Rohan for an excellent presentation and very concise. And to talk about this article, which has been published in Pediatric Clinic of North America. This is one of the most reputed journal what we all look at before it comes into the textbook of Nelson, our Bible and our guidelines of critical care books. As far as the selection of an article is concerned, absolutely it is very relevant. And it is one of the recent recommendation what we have looked into. And previously, we used to look at it in the ICCM guidelines of 2006, subsequently 2011, where the resource limited settings in an NAPOD, where the guidelines which is came, how to set up a PSU and all. Of course, our home IP Indian critical care guidelines we published in 2020 August, looking into the ICCM guidelines and all in Indian pediatrics. This is one of the latest thing what we are looking at. That's one. And this is an article which clearly defines how do we assess the need of a pediatric care unit. Previously, 2 decades back, where when we set up the SNCO at a public sector as well as a private sector, where a lot of guidelines which is came in that aspect, PAC is one of the things which is really needed, and that too in a community-based PACU is one of the things which is the need of the hour. Even though it was published in developed countries, this one, but it is very, very relevant to our Indian context too. Need of the assessment is one of the things where we all as a pediatrician we need to. Another challenging thing is, even though this article, which talks about a trained intensivist, yes, in India, almost India critical, our critical care chapter is one of the things which is started in a fellowship program, which is the most structured program. Now all our subspecialties now incorporating that. So how it is relevant, this article is, we talk about in a trained pediatric intensivist in each community, even in a community PSU. The presently India may not be that geared up to that, but trained pediatric intensivist the need. Till then, our general pediatrician can maintain that role. That's what we need to be looked. And stop is another thing where whenever we talk about the guidelines, most of the time we look at the other things, but something which is written apart from Indian pediatrics during COVID time, we used to look at it in a Indian Public Health Standard, IPHS standard. Even this article also 1:1 for an PHCUs and 1:2 for an nurses for an other things, especially non-ventilated patient, which is in a very, very need of the thing. And stuff is another thing, that is especially equipments. When we talk about the PHCU, most of the time what needs to be looked in. That's why this article, which is defines in a 4S: stop, stop, space, and system. As far as the stop is concerned, we talked about a pediatrician, pediatric intensivist, and nursing staff, and other supporting staff like a respiratory therapist, occupational therapist, and group D and other clinical, non-clinical staff, which is very, very important. Staff equipment is one of the things. What are the equipment which is required, and number of beds, how many beds we need to be. Of course, this is an article which is clearly defines if the less than 100 bedded pediatrics, where 6 to 8, but you can modify that according to the local situation. These are the general guidelines which is there. If it is more than 100 bed, where 8 to 12 PICU beds which is required, that's another thing. When you talk about the space, we say around 250 is ideal, but in Indian context we say 125 to 150 is quite okay in a developing countries like our India. But even when the guidelines which is came in the Nepal, even a 650 square feet, even 6-bedded PICU, that's the minimum thing what is required to that. These are all the some of the modifiable things. Ideally is 250, 125 to 150 is okay, but these things we need to keep it in mind. So that's which is related to space. System, clear-cut infrastructure creation, especially with a clear leadership role. That's another thing which is very, very important. Of course, this article also depends about the 6 core elements: how safe needs to be, and effective, and patient-centered. That's most. Whatever we set up, it should be patient-centered, and also it is a timely and efficient and equitable, both for those who are non-affordable as well as affordable. How it is going to be, that's also it clearly defines the core elements of our critical care. So, and the scope of services is another thing. When you are setting up, we need to know the geographically, what are the diseases which is likely to be, how do we prepare, that's another thing. And technological aspect. This is the one of the things where we are in the era of artificial intelligence, where previously we used to talk about tele-PICU, telemedicine. On top of that, how do we integrate our artificial intelligence like predictive mortality, like heart rate variability index, saturation predictive index, and other predictive model which can be used, and the lot of technologies can be used in a pediatric intensive care. That's another thing where this latest article which depends on that also. That means it covers up all the things, but only challenge and only limitation of this is how do we modify this with keeping the core objective of this to our developing countries like India. That's what it is defines. It's a very good article. Thank you, Rohan, for an excellent presentation, very concise thing. Dr. Mahesh is there, Dr. Satish Devpujari sir is there. Sir can add on to it.
Sir, Dr. Satish Devpujari sir, please give comments.
Yeah, so Dr. Rohan, very good article, and I'd gone through this article. Things have changed. Is about 35 years back that we are one of the early ICU in the country, and then of course, Dr. But you know, that reminds me of a book I did. Now, they would be about 10% because we have more sicker population. The ratio of nurses to patients is a very difficult proposition. But I entirely agree with you when you emphasize that there is a position of physician assistant. It's a very common position in the United States. And in fact, that is a kind of position we need in our developing country. So this is between a nurse and an intensivist. So physician assistant is a qualified position in US. And you know, when we were there, I had seen it very closely. This is what is necessary in our country. And the chapter has done a wonderful job by giving fellowships. So I think the article speaks very well, but then there would be issues with what happens in our country. And we need to adopt those to the realities. The ratio of nurses to patients is a very difficult aspect. And in between position of a physician assistant, which is a very common Because in the United States is what we need in pediatric intensive care. And that could fill up the nurse to doctor to patient ratio. So we need to change that ratio and get more fellowships so that they would fill up these gaps. But yes, this is a very good article. And this also relates to our article, which Dr. Khillani and our group had made of the way PISU should be designed in our country. So as such, it's a very good effort, and you had put it right in time and perfectly summarize it in time. Thank you. And of course, Mahesh had done a wonderful job in PSU in rural area, so he would be able to contribute as well for this. Thank you.
Dr. Mahesh Mohite, you are having first-hand experience. Please share with us.
In fact, I had given my experience in MAPEDICON 2020 in that oration, how the thing can be built up, but perhaps those are all about adversities. Rohan, it was a wonderful presentation. At the same time, I must tell you, PISU in general plays a pivotal role in any super specialty hospital, may it be in an urban or rural area. So even if you start setting up a super specialty pediatric setup, if there is no PICU, I don't think the super specialty can survive or can grow, because every super specialty requires a PICU on the backup. One with a good PICU setup, only those setup they grow. If they don't have a good PICU on the backup, usually there are some obstacles in growth of it, wherever it may be, either rural or urban. But at the same time, we need to understand the limitations this country has, our country. If I have to take the article which you presented in the context of Indian, for them, what you described is something which is like a tertiary quaternary in Indian, the kind of expectations you expressed. Perhaps in the rural area in India, perhaps our priority will be to stabilize the child and safely transport him to a bigger center where the facility is much better available. So we need better stabilizing center, and then we need good transport system. Fortunately, the transport system is improving now because of the good road infrastructure, but perhaps that should be our priority. Third, very important part is not the trained manpower. Yes, trained manpower over last decade or so, as Dr. Basavaraj said and Dr. Devpujari sir said, we have those fellowships started and we have almost trained 1,500 pediatric critical care fellows. The IIP chapter has grown. And now DM and DNP courses have started in last about a decade, but far before that, the pediatric critical care sector of India has trained almost, we have by this time trained almost 1,500 fellows, and they are to our kind of happiness. Many of them are practicing in the level tier 2 and tier 3 centers. So we have that facility, but bigger challenge, they go back and they find out the problem, biggest problem being the trained paramedical manpower. And the Indian Nursing Council gives kind of a deficit of nearly 1.5 to 2 million nurses in India as on today. Just now, there is a deficit of 2 million trained nurses. So go to periphery, any PICU, it's extremely difficult to get a trained nurse. And those who are trained, they may work for a few months and they go back. So ultimately, you have to choose from the local available semi-trained and non-trained and train them to this level. And then, like you said about the assistant therapy, the respiratory physiotherapist or kind of a respiratory therapist and all is kind of a distant dream for most of the centers, like a perfusionist or kind of a dialysis agent or something. Dialysis technician and all is a distant dream, especially in the PICU. Those are not perhaps apart from PD, you cannot really progress because of these multiple limitations. As Dr. Devpujari sir mentioned, like this ratio which you give out of 100 beds, 6 to 7 bed in Indian scenario, I feel at least 10% should be the ratio, because we get sicker children, they come late to you, and many of them do require. So even I would say in a 100-bed hospital, you may require 15 bed, 10 to 15 bed PICU and at least another 20 to 25 bed NICU. That's a requirement. So ultimately the proportion goes to collectively to around 35% of the whole, 35 to 40% of the whole kind of a thing. One more problem that we Indian scenario face is a hierarchy of support. So suddenly somebody installs a ventilation, surrounding 3-4 centers will go for ventilator installment just to show. And then ultimately the work is distributed and one particular center never developed the expertise in that. Same thing is happening perhaps in the ECMO center now. To maintain any kind of an expertise in a particular system, a unit must get a fixed number, a defined number of. So if you go to Europe, they have to have some 20 or 40 ECMOs a year. And here suddenly in a bigger center, you have bigger city, one center starts and out of competition, another 4 or 5 centers get an ECMO and they'll end up doing 1 or 2 ECMO a year. No one is going to develop an expertise. That's the biggest problem because the thing is not controlled. It's all industry driven and competition driven. So those are perhaps the things to be addressed to. In a Western world, since they are well regulated by the government system, then it is possible. Here is more regulated by the industry, and that's the reason these kind of drawbacks. So my perhaps the initial challenges and my priorities for developing PIs on the periphery is to have a better trained and more number trained paramedical power. The nurses, the rest of the technician, as Dr. Basavaraj and Dr. Devpujari also mentioned about assistant, nursing assistant, the kind of a nursing trainer, those kind of things. But those are the initial challenges. Rest, everything can be grown. You can buy a place, you can buy a premise, you can get the equipment, but you need a person, a good trained personnel to run those equipments. That only will really make a real impact. I believe as a person who has developed over maybe 30 years an ICU, I believe the biggest challenge is to get a good, persistent, permanent, trained manpower. So if that can be handled early, perhaps many of the things can be really taken to a higher level. Thank you very much.
Can I come in, please?
Yeah.
Yes, ma'am.
Please, madam, please.
Yeah. I just listened. I was just thinking, I would agree with Mahesh that we do not have legislation, sir. When you don't have a legislation and regulatory bodies to tell what exactly is to be called as a PICU, how much should be the manpower, because if you go and see, if you just walk across, you will see the boards PICU in many hospitals, which may not be actually having the setup of a pediatric intensive care unit. And I also want to know how many of our PICU trained fellows would like to go to the periphery, because they're not getting the setup. People are not confident to practice it there. They're very afraid. Neonatology is pretty okay. I find people more comfortable doing neonatology because babies are in the NICU. You don't get into much of litigation. But I don't know, this is my observation. I find that people shy away from doing PICU practice, particularly in periphery, without support system. They may be trained by themselves. And on the other hand, when you come to the cities and little bigger place, you see duplication of boards like PICU. But what is the legislation? What is the minimum standard required? What is the manpower? I don't know even whether our pediatric critical care has any kind of a regulatory system on this. Nobody needs to be registered. That's the first thing. And I think in India, the regulatory system should come in place if any of this sort of thing should work. It'll work in the Western countries because everything is very protocolized and streamlined. What about our Indian scenario?
No, I totally agree with you, madam. We do not have any regulatory system. Even though whatever the Indian pediatric critical care chapter, we're trying to bring in things. It is for our internal understanding and all. But as far as the law is concerned, yes, we do not have that regulatory system. But we whatever the guidelines which has been published in Indian pediatric in the August 2020, at least it is an attempt towards that. Previously, we did not have that also. We used to depend on ICCM guidelines. So in that context, I think we have initiated the process over a period of time. All these regulatory system may come over a period of time.
Yeah, because sadly, sir, we still see late referrals.
It's true, madam.
Still lives lost, had it been brought earlier. So we feel bad, like, they're progressing, but I don't know. In some places, we are a little bit, I think, going retrograde.
Our networking, our public health system, even the private sector, we have not been coped up to overcome these challenges. I think it may still require more time. I think Satish Devpujari sir can add on this with his experience. Sir, unmute.
So I entirely agree. Referral still continues to be a major issue. And even now we get such late referrals that nothing can be done. And it's like shifting a responsibility and not a patient.
Yes.
And this is what is happening. And we need to really work hard on that. But whatever happens, if a patient is referred at that point, then things get into bad shape and gives a bad reputation to the intensive care unit. So it is a major trouble, really. Hope things will improve. But I think AI will help a lot. It will help in triage development. And it will, I'm very sure, things will change in our field so much that the next 5 years we'll not even understand how things have changed in medical field. So AI will definitely help in these areas to a large extent. And relevant technology is important. We are still hugely importing technology, and you'll be shocked to an extent where exploited. Something which in our country will cost 10,000 rupees, we are exporting it for 1.5 lakhs. And we must really try and develop a relevant and an economically useful technology. That only will solve a problem.
Or sir, telemedicine and teleconsultations for small centers.
Absolutely.
Linking up with better bigger
I missed the
centers.
point. Yeah. Seriously. Absolutely. Yeah.
Thank you so much for all to all our experts for such putting so much light on this article. And actually, as Dev Pujari sir said, we are hoping that there will be some change and betterment in this in the rural places. With this, we come to an end to our today's session. I would like to thank Dr. Chitra Kulkarni ma'am and Dr. Niman Mohanty sir for getting articles for discussion and continuing this journal journey. And I would like to request Dr. Ajay Kohli sir, IIP, Raigad IIP Secretary, to please give us vote of thanks.
Good evening. Thank you, Dr. Shilpa. With this, we come to the end of an exciting session. Coincidentally, today is Doctor's Day, and also today we have completed like the silver jubilee of our journal journey, which had started and now it is at this stage. So I would like to thank first of all our guest of honor, Dr. Satish Dev Pujari sir, for sparing his valuable time and gracing the occasion. Next, I would like to thank Team MahaIP, President Dr. Ramakant Patil sir and Secretary Dr. Amol Pawar sir. They are always ready with guidance and blessings for us. Also, our Raigad IIP President Dr. Vikas More sir, who has been arranging this. Next, our moderators, Dr. Chitra Madam, who is the pioneer of Journal Journey, also Dr. Shilpa Nambiar sir, for meticulously planning and executing this wonderful session. Next, our speakers, Dr. Tejaswini Deshmukh ma'am and Dr. Rohan Bhagade sir, who have enthralled us with very relevant and practical topics and given a concise information on both. And next, I would like to thank Dr. Sara Dhanavdekar ma'am and Dr. G. Basoraj sir and Dr. Moite sir also for their expert guidance and putting things into perspective for us to understand. Next, I would also like to thank Dr. Neha ma'am and Dr. Jai Bhandarkar sir for their valuable help in this arrangement. Dr. Niman Mohanty sir for selecting the topics. And last but not the least, all the attendees who have attended the session on this webinar as well as on YouTube. Thank you all. With this, we come to an end.
And
Thank you all.
our
Thank you.
coordinator, Mrs. Pallavi Dharmadikari, for conducting this session.
Sorry. Thank you.